Hello and welcome to the Oncology Podcast, an Australian oncology perspective. For more info and to sign up to our weekly newsletter, visit our website oncologynews.com.au. Thanks for listening.
Hello, this is Rachel Babin from the Oncology Podcast. Welcome to another special edition of the Oncology Journal Club. This week we have our second post-ASCO 2020 review episode, hosted by the wonderful Professor Eva Segelov from Monash University. Eva is a medical oncologist and Director of Medical Oncology at Monash Health in Melbourne, Australia. As usual, she is joined by Dr Craig Underhill from Albury-Wodonga and Professor Hans Prenen from Belgium. This week, Eva interviews Michael Hofman about the TheraP trial that got a lot of headlines. Hans gets the ASCO Winners this week, Eva presents her losers, and Craig shares his favourite weird and wonderful papers from ASCO 2020. The banter only gets better, so once again you are in for an entertaining and engaging episode of the Oncology Journal Club. As ever, the links to all of the papers discussed today are available in the notes. This is Rachel Babin, and this is the Oncology Podcast.
Well, doesn't the week go quickly? It's time once more for our Oncology Journal Club podcast. And I'm joined by the best ever, Dr. Craig Underhill.
Hi, Eva. Thank you very much.
Hard to say something mean after that, isn't it? And all the way from Belgium, now with 9 listeners, Professor Hans Prenen.
Thank you. It's again a pleasure to be here.
Well, thanks for your hard work in recruiting 1 extra listener since last week. We're really on a great trajectory.
You saw I did my best.
So we're still on our post-ASCO theme. There really was so much at ASCO. We may be going for quite some time. But one of the major papers, not only for those of us in GI, but I think with wide ramifications, was the plenary presentation of the Keynote 177 trial, pembrolizumab versus chemotherapy for MSI-high, mismatch repair deficient, metastatic colorectal cancer. And so it's over to you, Hans, to tell us why this was such an important trial.
So the Keynote 177 was presented at ASCO, and as you said, it's with pembro versus chemo in MSI-high colorectal cancer. For inclusion criteria, they had to look at MSI-high patients, and you can measure this either by immuno, by PCR, by NGS, and in this study, only immuno or PCR by local testing were allowed. This was a phase 3 trial, open label, and the primary endpoint was PFS. There were actually dual primary endpoint, PFS and OS, but at this time they only presented the PFS data. And the standard of care chemo could be either FOLFOX, could be FOLFIRI, and could be either combined by bevacizumab or cetuximab. What was striking to me is that, Oxali, you had about 50% of patients and irinotecan, but for the targeted agents, bevacizumab was used in 70% of the patients, while cetuximab was only used in 11% of the patients. In total, 300 patients were randomized, and let me go now to the results. The PFS in the pembrolizumab arm was around 16 months, and in the chemo arm was about 8 months. So this is actually almost a doubling of the PFS. What was striking a little bit in the pembro arm, you could see that the confidence intervals are quite large, from 5 to 32 months, which is an extreme confidence interval. Also, what is for me striking is in the chemo arm, 8 months is quite low if you look in an unselected population. But of course, this was not an unselected population. This was the patients with MSI-high tumors. And we know from the CLGB study that also their chemo seemed less effective in the MSI-high patients. Another thing which I want to highlight is that the curves cross, and this is something very bizarre which we see in a lot of immuno trials. Also, if you remember from the esophageal or gastric data, we also see the curves cross, and here it crosses at around 6 months. So it means that the hazard ratio before 6 months favors chemo, and the hazard ratio after 6 months favors pembro. When looking at the subgroups that might benefit more for pembro, we see that there is less benefit in ECOG 1 versus ECOG 0. And also RAS mutations, they seem to have less benefit. Me personally, I don't have a clear biological rationale for this, why it's the case. On the other hand, if you look into BRAF, there is no difference for BRAF. And this is something we could have expected, but here there is no difference for BRAF. Also, toxicity-wise, as expected, the Pembro group does much better toxicity-wise than the chemotherapy group, with 22% grade 3-4 events versus 66% grade 3-4 events in the chemo arm. So it's a 44% reduction. To conclude, I have still a few questions with this trial. So what is the reason that 1 out of 3 doesn't respond to immune therapy, the MSI high? What do we do with the poor PS, or the Karnofsky scores that are lower, so patients with a performance score of 2 or 3? And will we see an overall survival benefit? But then again, it's quite uncertain, given there is also crossover in a lot of patients, so maybe we will not see a difference in overall survival. But beneath the data could be practice changing.
Thanks, Hans. I'm going to ask a couple of questions unless there are any from the floor. Oh, just a moment. Someone's on the phone. Hello?
Hello, Segelov. It's Vogel, New York.
Vogel, New York. How are you? You're the
Great.
most missed person.
Thank you. It was a pleasure listening to this podcast. I've got a question for the Belgian sidekick, Prenen. Prenen, I've been coming to this meeting for 22 years. You do not see curves like that in oncology trials. Is it no longer ethical to withhold this treatment from patients?
Professor Prenen, you're supposed to answer it.
I was so concentrating on his voice. Hi, Vogel, New York. I'm so glad that you could ask a question here. We were really missing you this year in ASCO. So I think it's an extremely smart and intelligent question. So why is it unethical that we use these kind of treatments when curves can cross? We see it in more and more trials. And the problem is all with the biomarkers. So when the curves cross, it means that early on, you might harm people with one arm while you have benefit with the other arm. While at the end, what patients care at the end is how long they live, so the overall survival and progression-free survival. And either we know upfront which biomarker can tell us which treatment will be the best treatment, or we don't. And then we will see for curves like this for the coming years, I think. So I think we have to accept it and still continue doing trials like this until we have better biomarkers. But again, extremely good question.
Thank you. I tried to text them on that virtual ASCO, but it just didn't work. So it's a pleasure to ask a question in 2020.
Vogel, New York, it's an honor having you on the Oncology Journal Club podcast.
Thank you, Segelov.
Bye-bye. Wow, how amazing. And now we're pleased to announce a special Oncology Journal Club podcast quiz. What is Vogel, New York's first name? Coming up, our exclusive interview with Professor Michael Hofman. Actually, it's not so exclusive. He seems to have been on every bloody interview. With his landmark presentation of his lutetium PSMA trial in metastatic prostate cancer. So now it's a pleasure to focus on some of the amazing Australian work presented at ASCO. And of course, top of the list is my very good friend, Michael Hofman, who had a landmark trial. Michael works at the Peter MacCallum Cancer Centre in Melbourne and has really led the development of theranostics for cancer, and in particular led the gaining of randomized controlled trial, high-level evidence for use, something that we sometimes poke fun at nuclear medicine physicians for not doing some of the time. Now, Michael does a lot of media and in fact often features on something called GUcast. So we're very happy, Michael, that you've agreed to come on our humble podcast. Michael, welcome to Oncology Journal Club.
Thanks, Eva. A pleasure to be with you.
So, Michael, you presented the TheraP trial, a randomized phase 2 trial of 177 lutetium PSMA 617 theranostic versus carbazitaxel in metastatic castration-resistant prostate cancer progressing after docetaxel. You presented the initial results of ANZUP protocol 1603. What did you find?
Yeah, so this was a Australia-wide multi-centre phase 2 study run by the ANZUP Clinical Trials Group, together with the NHMRC CTC. This was a 200-patient study conducted at 11 sites around Australia, including your own, Eva. Were you aware of that?
Of course.
And men who were eligible, those were men who had progressed after docetaxel, who were suitable for carbazitaxel, and they had to have a rising PSA and also a PSA over 20. And when meeting all the eligibility criteria, they then underwent both a PSMA and an FDG PET-CT to determine if they were suitable for randomization, and then randomized to either 6 cycles of lutetium or 10 cycles of carbazitaxel. Carbazitaxel given at a dose of 20 milligrams per meter squared 3 weekly, and the lutetium starting at a dose of 8.5 gigabecquerels and decreasing by 0.5 gigabecquerels. And the primary endpoint was PSA response over 50%, and that was achieved in 66% of the men in randomized to lutetium PSMA versus 37% of the men randomized to carbazitaxel, and that's an intention to treat. So a 29% absolute greater 50% PSA response rate in men randomized to lutetium PSMA. That's a fairly large difference in our primary endpoint, so we're very happy with that. And in these initial results, we also report the preliminary PSA progression-free survival. This is preliminary because follow-up is ongoing and the actual required number of events for this endpoint have not yet occurred, so it will change. But to date, we see a hazard ratio of 0.69 favouring prolongation of PFS with lutetium PSMA. And the other endpoint we report, which is important, is adverse events. This is the first randomised trial to report adverse events for lutetium PSMA. And overall, we saw less grade 3 to 4 severe toxicities with lutetium PSMA at 35% compared to carbazitaxel, which had 54% of men having grade 3 to 4 toxicities. So, the take-home message, I think, is that in men with progressive disease following docetaxel, lutetium PSMA was more active than carbazitaxel, with relatively fewer grade 3-4 adverse events and a PSA PFS favouring lutetium PSMA.
Well, Michael, you've obviously done that before, and this did get a lot of attention at ASCO, being an oral with such great results. So congratulations.
Thanks, Eva.
For those of us who don't treat prostate cancer, can you tell us the clinical significance of using a PSA response endpoint?
Yes. So PSA response is usually correlated with endpoints such as radiologic progression-free survival and hopefully overall survival in a population like this. But clearly, it is a surrogate endpoint, and this is only a phase 2 study, although we do have overall survival as an endpoint there, so we will follow that up. But it's fair to say when this trial was designed back in 2016, there was not a lot of data on the experimental compound, and we needed to power the study. And the data we had available at the time was around PSA 50% response rates. So we were able to come up with a robust power calculation to design this study. PSA is a very good biomarker for prostate cancer. I'm a nuclear medicine physician, and we report bone scans and CT scans, and I would say that PSA is a very robust biomarker in these patients with advanced disease. So we hope that correlates with ultimate outcomes, but it is an important limitation of the study to date.
Was there a minimum PSA that people had to have to go on, or could you go on with a PSA of 3 and see it reduced to 1.5?
No, so you had to have a PSA over 20, so that and rising, and that was as per Prostate Cancer Working Group criteria, which actually requires 3 consecutive measurements demonstrating a rising PSA, and additionally we had to have it over 20. So that makes this endpoint quite robust.
And were you able to collect any quality of life data?
We have collected a variety of quality of life data. All the patients completed the QLQ-C30, the EORTC core quality of life questionnaire, and also a PDF, patient disease and treatment assessment form. So we really don't have that data in this first analysis, but we will certainly report that.
Great. You should try and get as many presentations as you can out of the trial. Just a hint.
Oh, no.
So, Michael, can you anticipate in the future doing a sham or a placebo substitute or arm in a phase 3 trial? Would it be ethical to have people having a sham PSMA or nuclear medicine therapy?
Yeah, perhaps we should say a little bit about lutetium, because maybe not all the audience is aware of the experimental arm. Lutetium-177, PSMA-617, it's a small molecule labeled to a beta emitter, which is the lutetium, and it's given intravenously, and it binds to PSMA, which is prostate-specific membrane antigen. This is a cell surface glycoprotein that's highly overexpressed in metastatic prostate cancer, particularly castration-resistant disease. So it's essentially a way to deliver high doses of beta radiation to sites of tumour. Lutetium-177, Eva, you're familiar with it from your neuroendocrine world, bound to lutetium dotatate. But it has a 1 millimetre path length. So once it's taken up into these prostate cancer cells, it doesn't cause a lot of damage to surrounding normal tissues, given that short path length. And here, the main off-target effects are salivary gland uptake, which causes a dry mouth, and also lacrimal gland, causing a dry eyes. And it is renally excreted, although we don't see much in the way of renal toxicity to date. But it is obviously a very different class of treatment to cabazitaxel, which is chemotherapy. So we're comparing essentially a form of systemic radiation to chemotherapy. So I think we're better off picking an active control arm, as we've done in this study, so cabazitaxel, or if you wanted to go earlier, you would compare it against a novel anti-androgen, such as enzalutamide or abiraterone, but comparing it against the sham when we have already efficacy data that we, probably superior to cabazitaxel, I don't think would be ethical. And there are a lot of logistical difficulties in having a sham arm in a group of patients having a radioactive treatment, because patients are radioactive afterwards, so they need to take particular precautions. It's also quite easy for patients to potentially unblind themselves, because you can now actually get a mobile phone app that'll measure radioactivity, believe it or not. I'll tell you how this works for fun. So it would be possible for a patient to download a simple app on their phone and measure crudely whether they're a little bit radioactive or not.
Sure. So we won't see Carbazi plus or minus lutetium with a sham arm or any other variety. We'll always know that we're comparing active radiation with whatever we add or compare it against.
Yeah, I think it's just a little bit harder to blind a radioactive treatment than compared to a tablet that you swallow, where you can have a sugar pill or sugar infusion instead.
So there has been some concern, particularly longer term, of the lutetium on bone marrow. Your trial was in the second line. Patients are heavily pre-treated. They already have bone marrow disease in many instances, as well as bone disease. Can you comment firstly whether you think this will impact the ability for subsequent chemotherapy? And secondly, whether this could be a problem if you move this therapy into earlier lines?
So if we just look at the toxicity, we had a 13% incidence of neutropenia and or neutropenic fever with cabazitaxel. I think 7% of men had neutropenic fever, compared to 4% with lutetium PSMA. So much less neutropenia with lutetium PSMA, and not a single episode of febrile neutropenia in the lutetium arm. If we look at platelet counts, we saw a higher thrombocytopenia with lutetium, which is what we expect. So 11% of men had a grade 3 to 4 thrombocytopenia with lutetium, compared to actually none with cabazitaxel. So that's the acute hematotoxicity profile. We get less neutropenia, but more thrombocytopenia. I don't think there were any episodes of bleeding as a result of the thrombocytopenia, so I hazard to say I'd probably rather have a reversible thrombocytopenia than an episode of febrile neutropenia. So acutely, I think it's fair to say that lutetium has a better hematotoxicity profile than carbazitaxel chemotherapy. And anemia, for what it's worth, was very similar between each arm. In fact, 8% of men had a G3/4 anemia in each arm. Longer-term toxicity, well, we really await. The concern here is actually myelodysplasia or some forms of leukemia after lutetium therapy. To date, we have not seen any episodes of myelodysplasia following lutetium PSMA, unlike lutetium dotatate, where we see a 4 to 5% incidence of myelodysplasia with longer-term follow-up. So I think the mechanism of hematotoxicity is very different between lutetium PSMA and lutetium dotatate. I think the somatostatin receptor that dotatate targets is expressed on hematoprogenitor stem cells, so we do get a lot more marrow toxicity with lutetium dotatate. But in truth, we need longer follow-up because these men have a limited life expectancy at this stage after several lines of therapy. If we bring it back earlier and earlier to the first-line treatment, which we are doing, I think we do need to be cautious and monitor men for long-term side effects.
So, Michael, your conclusion was that this was a potential new class of effective therapy, and I have no doubt that patients at Peter MacCallum will be able to access this immediately. But how about those in the rest of Australia and globally? What's the situation here?
So if we start with Australia, I mean, this study was run at 11 sites, and care of ANZUP, who ran this trial. We now have 2 more trials that are either running or up and running. One is called the Upfront PSMA trial that I'm leading with Arun Azad, a medical oncologist who used to work with you. And in this trial, we're giving lutetium prior to docetaxel in newly diagnosed men in a phase 2 trial and randomizing it compared to docetaxel. And there's a second trial led by Louise Emmett in Sydney called the ENZA-P trial, which is essentially in the castrate-resistant enzalutamide plus lutetium PSMA versus enzalutamide alone. So there will be trials open at these 11 sites, and we're actually adding a 12th site. And we hope to open many more trials and eventually have this product both registered and reimbursed by government so it can be really more widely available. And globally, there is a phase 3 trial called the VISION trial, which is comparing this agent to a best supportive standard of care in men in quite a similar population to the TheraP trial, so post-docetaxel, post-enzalutamide abiraterone. And that trial is a 850-man trial which has completed recruitment, and we're waiting for the results of that. It may be reported at ESMO, but it is an event-driven trial, so I'm not sure if the number of events would have made it for ESMO, and that's an FDA registration level trial. So if that trial reads out positive, I think we can expect this to become an FDA-approved agent maybe in 2021, and when it's FDA approved, that generally leads to a global widespread availability, but we really need to await the results of that phase 3 trial first.
Is it something you would anticipate would be taken up and given in private nuclear medicine centres?
So there is a fee-for-service operation in Australia where you can purchase lutetium PSMA if you can afford it. It fills a need for men, but I think the onus, at least I work in a academic public institution, and we don't want treatments to be available to men who can afford it versus men who cannot afford it. So we really want this to be available to all men.
Rightio. So, Michael, this may be a very ignorant question, but that's okay. This is my podcast. Could this even play a role in early disease and potentially be organ sparing?
We actually have a study open called the lutectomy study. It's a bit of a take on a prostatectomy. We take this is a study led by Declan Murphy. This is a Peter Mac study, and we are giving a cycle of lutetium prior to men with high-risk prostate cancer who are scheduled to have a prostatectomy. So they have a cycle of lutetium, the first 10 men, and then the second group of 10 men will have 2 cycles of lutetium, and all men will proceed to a prostatectomy and pelvic lymph node dissection. And we will look at whether we can achieve any pathologic responses with lutetium, and we'll also have imaging before and after the lutetium. And the primary endpoint of that study is actually dosimetry. So one of the nice things with this theranostic concept with lutetium is that we can see what we treat. So we can put patients under our nuclear medicine gamma cameras after the treatment and quantify quite precisely how much radiation has been taken up into both tumour tissues and normal tissues. So we'll be able to quantify and say, this prostate tumour got 50 gray with a single dose of lutetium, and that will be very useful information. So I think it's looking very, very far ahead, but it is possible that this could be a treatment for men with primary prostate cancer. It is possible. It is a way of delivering radiation, and we know that external beam radiation is widely used as a treatment with curative intent in men with high-risk prostate cancer. So it is possible that in the future, lutetium could be a treatment of choice for men with newly diagnosed disease, but we're really a long way away from that. We need the evidence base first, and the current standard of care is definitely either surgery or external beam radiation.
So, Michael, you've mentioned a number of times that this was done through the ANZUP National Academic Trials Group. How important are these trials groups, and should everybody be involved in a national trials group?
I think ANZUP was critical to the success of this study. Coming from a nuclear medicine world, we actually generally don't conduct clinical trials. We just perform scans and give treatments. And this was really a good part.
Quite a change, isn't it?
It's a huge change. And this was quite a close collaboration of nuclear medicine experts and medical oncology experts all sitting in the same room together with our biostatisticians and clinical trial experts designing this study. And I think that's quite unique, and it's come together really nicely. And certainly the nuclear medicine community on its own does not have the expertise to do these sorts of trials. We don't have the experience. So we do need these collaborative clinical trials, cooperative clinical trials groups. They are really critical, and ANZUP have done a great job. I would say perhaps even better than industry. When we look at the trial design, it's a real rational trial design with an active control arm. Some of the industry trials we see have quite nuanced trial designs designed to produce a positive result, but this was really a patient-centered trial, and I think that's another thing a cooperative clinical trial group does well. They answer a really relevant question, and it removes any sort of commercial or industry bias as well.
It is really remarkable because, as you know, for neuroendocrine tumours, lutetium dotatate has been used as a treatment for many, many years without any randomised trial data. It took a very, very long time for randomised trial data to be generated. And even then, there was a lot of scepticism amongst people who'd used a lot of this agent that it should even be exposed to a clinical trial. So congratulations, Michael. You really are the father of theranostics in Australia. And I think globally, Australia really is leading this. It's a wonderful study. It's a very collaborative study and a very meaningful study with lots of follow-ons. So it's been our pleasure to have you here at the Oncology Journal Club. So thank you.
Thanks, Ian.
And good luck.
Pleasure. Nice to be with you.
So, Hans, you got one extra listener this week, and therefore you get to do the winners. And I will do the losers section. So, winners and losers, part 2 from ASCO 2020 Virtual. Over to you.
So the first winner, and it's actually published in the New England, it's called the HERO study. So it's a study that cannot fail. And it's with oral relugolix. I practice a whole day to pronounce this name. So oral relugolix for androgen deprivation therapy in advanced prostate cancer. They compared this oral drug, it's an oral gonadotropin releasing hormone antagonist, and was compared with injections. And what they found is that it suppresses testosterone levels quick, and it was superior to the gonadotropin releasing hormone antagonist, with also 54% lower risk of adverse cardiovascular events. So it's a great winner, I think. A second winner is presented at ASCO, and we were actually waiting for a very long time for this data. It's in GIST tumors. You know that we give 3 years of adjuvant versus 1 year. There's a study, and now there is long-term overall survival. And actually, there is a winner for 3 years on overall survival. Another tumor type, also rare, is gestational trophoblastic tumors resistant to chemo. They can now be treated with avelumab, also shown at ASCO 2020 with very good results. And finally, a study on CAR-Ts published in GCO. It's a phase 1 with patients with metastatic HPV-16 positive epithelial cancers treated with CAR-Ts against HPV-16E7, and it was a phase 1 but showed clear clinical activity. So CAR-Ts are finding their way into solid tumors.
Thanks, Hans. Some exciting results there. So now it's left for me to present the losers of the week. I'd just like to put a special mention in for Lancet peer review, even though that wasn't for ASCO. Not so prestigious now, perhaps, to have published in the Lancet. Other losers were, of course, the virtual meeting itself. And I know that ESMO will be virtual this year, hopefully less technical problems. But they did get a record attendance at ASCO with over 45,000 people tuning in. So surgery was a bit of a loser this year at ASCO. First, we had the plenary showing no benefit for local therapy in metastatic breast, but we also had the 20-year follow-up for PFS of 97% for one cycle of BEP in low-risk germ cell tumours versus retroperitoneal lymph node dissection, 92%, and obviously no residual toxicity. Less surgery is also better than more. An abstract 6501, a French randomized multi-center study, told us that going forward for elective neck dissection, a sentinel node biopsy is equivalent for T1 to 2 N0 oral and oropharyngeal squamous cancers. So sentinel node rather than neck dissection, I know what I'd rather have. There was one more surgery being better with yet another secondary debulking trial in ovarian cancer. The principle of continuing to study something until you get a positive trial. And a sobering loser was the data showing that early adult diagnosis of colorectal cancer is growing significantly. The incidence in the population under 50 has risen 51% since 1994, and the sharpest increase is in those aged 20 to 29. And by the year 2030, it's thought that we'll have a staggering 124% increase in younger patients. So hopefully, Hans, pembrolizumab and other drugs will really change the outcomes for these patients.
So Eva or Hans, what's the postulate there of what's driving that increase in the younger patients? Is it obesity or?
I don't know. Ask Hans.
I think we have no clue. It's probably an environmental factor, but I cannot say anything sensible about that.
There's a change.
It's a very concerning trend. There's probably many factors, none of which really account for it, but it does challenge our current paradigms, particularly around screening and also symptoms in younger patients, which are often not investigated by colonoscopy because these patients are thought to be too young to get colorectal cancer.
Yes, I've had the same experience, Eva, with some late presentations in young patients who've had symptoms for many months and not really investigated as you would in a 50-plus-year-old.
Sobering.
So, Eva, can we just quickly discuss the paper that Hans presented on the Ligarelix? Because I think that'll be potentially a game changer for the switch over that drug and also some cost savings to the system because it's an oral agent rather than a subcutaneous agent.
Yeah, sure. I've got a question actually about why there are so many less cardiovascular effects if it's got the same on-target effect.
Well, I think it's probably the mechanism of action. So we know Ligarelix, which is an intramuscular monthly injection in the same class. So these are GnRH antagonists that block the production of luteinizing hormone FSH by the pituitary, driving lower testosterone production. So an immediate reduction in testosterone, whereas traditionally we've used the GnRH agonists, which cause a surge in production and then a negative feedback loop to cut that off. So you get a surge in testosterone production, you get patients becoming overweight, insulin resistance is a problem, there's a hypothesis that increase in FSH in the vascular level causes T cells to be activated and a fracturing of atherosclerotic plaques. So there's some retrospective data from Degarelix, and this is a prospective study that has shown the same effect. So it's quite interesting. So it's an oral agent, so patients don't have to come into the cancer centre or their GP's office to have an injection. But I think, compliance will become an issue. So we know, in breast cancer, for example, there's not 100% compliance with hormone agents. And let's face it, men are pretty hopeless at taking medication, or some of them. So that could be an issue. This has a short half-life, and if they don't take it every day, they might have fluctuating levels of testosterone and less effect. So we'll have to monitor their testosterone levels, I think, as part of the management paradigm with this drug if it goes onto the market.
Thanks, Craig. And can you just say the name of the drug again?
Degarelix?
And Hans?
Is it?
Relugolix, I would say.
Somebody's got it backwards.
Relugolix?
Relugolix.
Relugolix. Relugolix.
Relugolix.
Relugolix.
Relugolix. Yeah. Poor Rachel. Rachel thinking, why did I ever agree to do this?
So now it's time for the long-awaited weird and wonderful abstract from ASCO.
So Eva,
and who better to present that? Can you stop?
Sorry, I thought you paused. I thought you wanted me to
always interferes.
Can you stop interrupting? And now if I can get through an introduction without being interrupted, here's Craig.
Sorry. Thank you, Eva. I picked out 4 abstracts just to mention quickly. These were all poster presentations. 2 I put in the class of stating the bleeding obvious. And 1 was if you optimise the education of clinicians about the management of glioblastoma, they learn more and they're more comfortable in managing that tumour. So that was really fascinating. Another one, if you intervene in breast cancer patients who are overweight for them to lose more than 5% of their weight, they report better outcomes and more well-being. Again, stating the obvious, possibly. The third one was possibly ahead of its time, but what were they thinking? It's a phase 1-2 trial assessing hydroxychloroquine and itraconazole in women with epithelial ovarian cancer. And guess what? There was no activity, but there was patients with hypokalemia and cardiovascular events and arrhythmias. So,
well, they'll get in the Lancet.
That's right. And then the last one, proving that really you can submit anything to ASCO and you'll get a poster. And this was a paper by a group, and the last author was Eva Segelov. Eva Segelov from Melbourne. And this was an analysis of the ASCO Global Oncology Journal of where people downloaded, which countries are from, and where the countries that they contributed from, and that was managed to be stretched out enough to fill a poster. So well done to those authors.
So very important bit of data looking at collaborations between low and middle income countries and whether there is bias in publications.
Sorry, I was possibly being a bit harsh there.
Don't worry, I can understand that. You might not have understood it.
I wanted to encourage all of the trainees listening that the most important thing is to have an idea, get it down on paper, submit it for a poster, get a publication.
And puts Eva as senior author.
Anytime. So sadly, we've come to the end of another podcast. It remains for me to thank very much our wonderful friend from Belgium, Hans Prenen.
Thanks, Eva. You did a great job in hosting today again, as usual.
And thank you very much, the wonderful, the one and only Dr. Craig Underhill.
Thank you, Eva. And thanks, Hans and Rachel. Have a great weekend.
So that's it for this week for the Oncology Journal Club. Join us next week for some more wonderful analyses and lots of interruptions from Craig. Keep up to date. Bye for now.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.